think we'll get started. Heather's on, Nancy's on. So I just want to thank everybody for taking some time out of your day and nice and early at 8 o'clock meeting to jump on here. I appreciate that. And I think today's really a mix of informational as well as some recommendations aimed at really keeping our health plan strong, sustainable, and affordable for all of our employees in the district. As you probably already know, healthcare costs continue to rise nationwide, but we really want to stay ahead of that and avoid sort of what we were in before that we've been trying to get ourselves out of, right? Where we kind of delayed any increases for a while, and we found ourselves needing a really much larger ones. But we're trying to stay ahead of that now. I know we have for most employees a plan that carries us through this year and 2 more. With SEIU, we still do need to return to the table to talk about plan year 26. But here we have some recommendations here that we're going to go through. So there we go. So last year, just a recap for most employees, and this is everybody except SEIU. We did agree to these 3 years of 3 plan year increases. As well as the district putting $30 million of one-time funds to bolster the reserve and shore up the plan. And so we will be returning with SEIU to talk about our plan year 26 with you. And but at the same time, we felt it was necessary for you to be part of the decisions that we're looking at in adjustments to the plan and things that we're already doing, but also things that we're planning on. We recommend doing. Some of those things came out from our conversations with the coalition last year, recommendations that that the coalition had. So with that, I think I'll turn it over to Nancy and Heather to lead us through some of these things.
Okay, so next slide. So I'm not sure who's controlling them.
I got it.
Oh, you do? Okay.
Yeah.
All right, so as Mr. Kubrick mentioned, we already have a 3-year agreement with increases in health premiums. And when we agreed to that, we've been very transparent about the status of the plan. We knew even with the increases in premiums, it wasn't going to be enough. When you get to plan year 27, you can see the premium increases are not enough to cover what the expected increase in plan expenses is supposed to be. And so we said, even though we've agreed to premium increases, we're still going to continue to meet because we need to continue to meet on cost containment efforts and keep everybody updated as to where we stand so that, like Mr. Kubrick mentioned, by the time we get to plan year 28, we're not looking at substantial increases in health premiums. We'll just be able to continue those nominal increases in health premiums going forward. Okay, next slide. So what we're already doing for cost containment, we have implemented this glucose monitoring program, which is completely voluntary. That's estimated to save $1.8 million. We're implementing and partnering with People One Health Centers, which we did a presentation with the coalition group, and that's estimated to save $1.8 million. People One, though, has an additional cost per member. And so those that are going to be eligible are those that have agreed to the 3-year premium increase. So that will be, this People One option will be available as of right now for CTA, PBA, and non-bargaining members. We're making some slight changes within the prescription drug plans related to the GLPs, which is a small estimated savings of $300,000, but that every little bit helps. So we're looking at everything we can in order to contain costs so that by the time we get to plan year 27, we are at a break even. And then we're adding a 4th plan option. And that 4th plan option is going to be priced the same as the current low option plan. And that option is projected to save $2.2 million. And Ms. Bolton is going to walk through what that plan is. So we're not removing it, it's just adding an additional option. So Ms. Bolton.
Mm-hmm. Okay, so the Surest plan it's an innovative, technical consumer-driven, sort of the next generation of the consumer-driven plan. So as Heather mentioned, it would be offered as the fourth plan, completely voluntary, not in place of any of our three plans, but in addition to it, beginning in plan year 26. It's co-payment driven. If you look at this little illustration here, it almost looks like an Uber app to me, but it is not an Uber app. It is a very technological app that is fortified by the existing United Choice network. So members shop their healthcare services according to local providers and prices that show on the app. The Choice network has no disruption from current network, and it's designed toward lower cost copays for the higher value services. So our HMOs have lower copays for primary and specialist care for our tier one, so-called tier one providers that drive more value in care based on just their services and the underwriter's determination of how they treat patients. So it's based on that model. So if I needed to go to a primary care physician for a sore throat, for example, I would type that into the app. The app would pull up as shown in this little illustration, and it would tell me where my primary care doctors are. And I would choose whatever I wanted. If I wanted to go with the cost, there's a $20 PCP out there that I would choose. Tim, next slide. So here's kind of how it looks. It is new again. So there's no deductible, no co-insurance, just these clearly identified copays. So as I mentioned, the lower copays have the higher value providers, and they're evaluated by cost, efficiency, effectiveness, patient reviews, all of that, certifications. Copays include the services delivered in that visit. And so there are no follow-up balance bills or unexpected bills. Members can search ahead of time and know what they're going to pay. So it's very transparent. It's very innovative. United acquired Surest from a company called Bind, I think it was, in 2022. We think that it's a product that might appeal to our younger, newer employees or those technical leaning folks, and it's just taking off. There are now over 1 million lives covered under this plan, and lots of private sector companies are adopting it. And so we're excited about the opportunity to offer it as a voluntary fourth option. Next slide, please. So here's just kind of a plan design comparison. This is a busy slide, but here are our plans, just some of our benefits summarized side by side. So you can see that the copays vary under Surest, but there are no deductibles, no co-insurance. There is an out-of-pocket max, so you're not going to spend more than $6,500 in any given year, but you're going to know what you're going to spend when you seek care. Next slide. And then additional options. Heather, do you want me to continue? Or?
Yes. Yeah. So with so now we have 3 additional options. The first option was something that was recommended by the coalition bargaining group last year. It was brought forward, and we researched, and we are recommending that we do proceed with that. It would be replacing the low option HMO with the neighborhood health plan. That is estimated to save $1.9 million. United is working hard to make sure that all doctors that are on the current plan would remain on the neighborhood health plan. It's over 98% of the doctors are on the same plans. And it's not a gatekeeper model, so it's not much different from the low option plan. Employees would be required to select a primary care physician but you don't need to go through that primary care physician in order to seek other care through other specialists. So you would still be able to go directly to a specialist. And you say, well, how is that different and how would that save money? The way that it saves money is the primary care physician is the one who's coordinating the care. So if you go to one doctor, they ask for an x-ray. You go to another doctor, they ask for an x-ray. All of that is forwarded to through your primary care physician. And so your primary care physician would tell the second doctor, oh, they already had an x-ray, here it is, and send them the x-ray instead of you going out and getting another second x-ray. So we recommend that replacing the low option plan with a neighborhood health plan. The second option is a premium change. We are recommending that we do not increase the high deductible premium by the $18 per paycheck that we agreed to with the bargaining groups, and that for the employee only option plan. So it would remain at the current premium amount, which Ms. Bolton is $106.
116. Let me just grab that.
And that would be an additional cost because it would be lost revenue to the plan. But we're recommending that we keep that premium the same without doing that $18 increase. And then the last is plan design changes related to deductibles. And as we were working through with the plan actuary, he mentioned that we have not made changes to our deductibles in several years. And so as the cost has increased and the claims have increased, the cost of claims has increased with medical inflation, he did recommend that we increase our deductibles. That's just normal housekeeping of any self-insured plan because everything else staying steady. If we were not to increase those deductibles, the plan would then end up being structurally imbalanced. And so we're recommending to increase the annual deductible by $100 on both the low option and high option plans, which would save $1.8 million. And for the specialist copay, it would increase by $20 per visit on both the low and high option plans.
And
So
Heather, if I may just confirm that rate for the consumer, the CDHP is $116 per month currently.
Okay. And so it would stay at 116 instead of increasing by that. That's per month. So instead of increasing by $36.
All right. Heather and Nancy, do we want to talk a little bit about anything about how being on the high deductible would possibly save them money, or what the difference would be?
Well, the high deductible plan does have a consumerism sort of impact, aspect to it, in that it does have a high deductible, but the district provides a health savings account option. If employees want to opt into it, we really want them to opt into it. The district seeds those funds. And so over time, the HSA is a savings mechanism that will pay some of those costs incurred under the high deductible, but employees are motivated to really think about, if I have a sore throat, maybe I'll go to my PCP and pay $25 or $30 instead of, the ER that's going to cost me and the plan more. They want to save that money. And the HSAs are neat because when employees retire, they can actually take that money with them and use it to spend on health-related costs in their retirement.
Right. It rolls over each year, whatever balance is remaining. It's not a use it or lose it like the FSA. So the HSA has a huge benefit to employees that it is their money. All right, so next slide. And I think I walked through the neighborhood health plan, but is there anything, Ms. Bolton, that I left out that you wanted to highlight?
Did you mention that we pursued this after you all brought it to us in one of our bargaining sessions last year? And so we did look into this at your recommendation. So, it's just a smaller, it's just a more cost-effective network, but it would be relatively seamless to our employees. They would have to choose a primary care physician, but again, it's not a gatekeeper. They don't have to they can still self-report to specialists, but that's why the actuary and I know that increases in deductibles and copays are, those are difficult conversations to have, but the actuary specifically recommended those two components because of our referrals to specialists. There's not a lot of daylight between the primary care physician and the specialist. And sometimes a primary care physician can resolve an issue conservatively. And so the actuary thought that this difference, this kind of spread between copays would sort of serve to drive people to their primaries before self-reporting to an actuary or to a specialist. Still be able to do it if they want to, but the network health plan is really intended to keep you with your primary, kind of that old medical home theory. And so it should drive some costs down, not 2%, but because our costs are so high, that matters. And so the plan would be expected to ultimately save the HMO some money while being relatively seamless to our employees.
Okay, next slide. So like we saw on the first chart, this actually is the numbers behind the chart to show that if we don't make any changes, if we didn't make any changes to the plan, we would be looking at a $13 million shortfall by plan year 27. So with those cost containment measures that we're putting in place, by plan year 27, we would be at a break even in the plan, which means we'd be able to keep those nominal increases in premiums where the district is paying $11 and employees only $6 per pay period. So that's our goal. We want to get from digging ourselves out of a hole come plan year 27. We want to be proactive and continue with whatever cost containment and saving measures that we can put in place so that our plan is structurally balanced and we can just have nominal increases going forward. Next slide. So now you can see the difference from the first chart to the last chart. The yellow bar, the premiums are now sufficient in order to cover the plan expenses, and our ending fund balance is in compliance with state regulatory requirements if we were to implement those changes. All right, so just a recap of the proposed changes to the plan is replacing the low option HMO with the neighborhood health plan that was recommended by the coalition last year. So we, after researching, with our actuary, we were able to prove out that will save an estimated $1.9 million per year. And it really should be seamless to the employee other than having to select a primary care physician. Other than that, they don't have to actually go through that primary care physician. They can, direct report, like Ms. Bolton said, directly to any specialist they want, like they do now. Recommend the premium change in the high deductible plan, keeping that the same with no increase of the $18 that we had recommended last year. And then the plan design changes, which really come down to housekeeping, increasing that annual deductible by $100 and increasing the specialist copay by $20. And both of those will save, nearly $3 million per year.
So I guess at this time, we welcome your input. If you got any ideas or suggestions, we'll turn it over to you now.
Yeah, so I've got a few questions before I get into what our position is with regard to these negotiations. But tell me about the People One health centers that are opening January 1. What services will be provided? How do employees access it? What cost will that be, et cetera?
For those employees that elect to participate in People One, and it's going to be open to the eligible employees that have, already agreed. So CTA, PBA, and non-bargaining. It's completely free option for the employee. So that would be their primary care, although they could still elect to see other doctors. It doesn't take that away from them. And there's no copays. There's no copays even on specific drugs. There's also no copays if People One primary care refers them for an MRI. There's no copays on the MRI, sleep machines, sleep apnea, whatever, different services that are referred to them. It's all no cost to the employee. So the plan pays a fixed amount each year for each employee of $1,900. Is that correct, Ms. Bolton?
19, yeah.
And then the employee so the plan is paying that, and then there's no additional cost the employee pays when they actually go and visit.
And then the Surest plan that you're rolling out. So I saw, I'm familiar with the plan a little bit, but when I hear innovative and consumer driven, all that tells me is they're trying to avoid claims, which means they're trying to get employees to avoid service. When you look at that and you say, oh, look, it looks like an Uber app, are you really just saying we're trying to get you to go to the cheapest provider?
I would say just to get to what you said, that it's to drive them to a lower cost care. It's really, truly an innovative option that we expect younger employees to elect into. It's not because we're not recommending to replace any of our plans. I would say if we were replacing one of our plans, I would agree with you on that. Potentially people might think that because it's why are we replacing it other than to drive people to it? This truly is giving them a fourth option for those people that want to know what they're paying and they're good with technology and they don't really want to talk to people on the phone. They want to just go on their app, see where they are, and it's very easy access. So it's really, truly just another option for employees.
And when we talk about the high deductible plan, so you said that you're going to hold that premium at $116 as far as what the employees would pay. I have outdated numbers, so I don't have current enrollment numbers. Do you know by chance what percentage of our bargaining unit employees are in that high deductible plan?
Of your particular bargaining unit, I don't think we would be able to get that number. It is the smallest enrolled plan. We can tell you that. And it's because a lot of people don't know and understand the high deductible plan. It is, and for some people it's a little scary, but I know that our previous risk and benefits director, she's like, if I was young and I was just starting the district, I would 100% go in that high deductible plan because that HSA just continues to grow and it stays with the employee. It's a huge benefit, but some people really just like to know that they have the health insurance and don't want to have to worry about that. So it really is a personal preference, but the high deductible plan was priced higher than all of our other plans. And the reason why it was previously priced higher was because we wanted employees to really research before they went into it. But we do feel it is truly a good benefit for employees, and a lot of employees have not been electing to participate in it. So that's why we thought it was better to keep the premium the same. So it will now be the lowest employee-only option. So that's why we're recommending it, even though it is a lost revenue and will be some additional cost to the plan. We do ultimately think it is a good benefit for employees, and we want them to really consider it as an option.
Okay. Under the PBA and CTA agreements, those premiums were scheduled to go from 116 to 152. Have you amended those agreements?
Well, that's part of this discussion. Yeah.
Well, see, so that was a few bullet points down my list, but I don't understand why the district's calling this coalition bargaining. You struck 3-year deals with the PBA and CTA, and you imposed on us what becomes under law a 1-year deal. Why is this coalition bargaining if the PBA and CTA are under contract?
Well, it's really this meeting wasn't necessarily even bargaining. It was as much. I mean, it obviously it's more like impact bargaining, I guess you would say, to try to come back and talk a little bit. We're about what we're doing now, some of the things that we're already doing, just plan design changes that normally aren't bargained. But then also some options, because really, during negotiations over the last 2 years, there were a lot of things floated and ideas. And last year we talked about the neighborhood health plan. So we know to do that does need to be bargained, right? That, swapping out a low option plan for the neighborhood health plan does require us to bargain it. And it's not something that anybody has to agree to, but our goal here really is just to make sure that at the end of this, we're not in a situation where we're falling behind again. So we're not, just because we have a multi-year deal doesn't mean that we're going to sit back and just wait until 2027 to start looking at, well, what's the status of our plan? We want to stay ahead of this and make sure that we can, make any changes that are necessary now and avoid any sort of, larger increases later. And we're also trying to, make, I'm not sure how far along we were with People One before you joined the bargaining sessions, but that is something that we've really tried to, we know that the costs of the premiums that impacts our employees. Nobody likes a premium increase, but that was really designed as an option where if you're using a doctor and you're going and you're paying co-pays and paying prescription drug prices and stuff like that, that is something that would just be a tremendous benefit. So we went out there and brought them into us to try to give another option for our employees to, while their premium might go up a little bit, we think that their savings that they're going to see from using People One would be greater than what the premium increases would be. I know for a fact, as soon as it's available, I'm signing up for People One. No question about it. It's no copay when you go to the doctor. If I need prescription drugs, a lot of them are covered, and MRIs, X-rays, all that stuff. I mean, that's going to add up. So we're trying to just put forth some effort to make sure that our employees do have options that maybe can scale back some of the costs of the premium increases.
Yeah, and listen, I mean, there's no argument that this sort of clinic-based care is, the at least trend currently. I don't know that it's the way of the future. I don't know if you need any more proof than Amazon's opening its own clinics, right? I mean, they just opened up 3 clinics between Broward and Dade County, and if they opened one in Palm Beach, we'd probably all be on board because they appear to be doing a good job of it. And we've had several other clients that have been able to, even in our self-insured funds, open their own clinics, and it does result in significant savings, in reducing those claims. So I'm all for that. I think what I was really driving at is if you have you've got 2 more years, 26 and 27, under your collective bargaining agreements with the PBA and CTA. I don't see them present in this meeting. So have they indicated that they're willing to come to the table and amend those agreements, or are you just trying to convince them that, hey, this might be a good idea?
That's really, we're trying to convince them. No, okay. PBA did say that they're not interested in returning to the table right now. So that's something we'll have to work on with them and try to. We're just trying to share information here. I mean, it is a coalition, right? And so we're trying to share all this information we can. There are a lot of questions over the past few years about, well, why are there the premiums? Why are we falling behind? Why are we asking for big increases now? And I think it's because some of this kind of stuff wasn't considered. Heather and Nancy have put down a lot more options, over last year and in the future that we're recommending here that just weren't happening maybe, for many of those, 10 years that we saw no premium increases. And it put us in a tremendous hole that we had to dig ourselves out of. So rather than, keep going further in the wrong direction, we're just trying to change things up and put these options out there. And if we could collectively agree that, yeah, this makes a lot of sense for us, then let's do it. That way, when we get to 2028, we're like, yeah, no problem. We're the plan's in good shape.
Yeah, I mean, look, I can tell you from our perspective, we're all in favor of the People One. We're in favor of replacing the low HMO with the NHP. I think that that's a fantastic idea. But from our perspective, it really comes down to dollars and cents, right? What are the employees required to pay? And I think we made our position pretty clear in the last negotiations over this, that we're not on board with this coalition. It's not coalition bargaining anymore as far as we're concerned. We think that if you look at the salary disparities between the CTA, PBA, and the SEIU, we have to have options that our lower wage earners can afford. And so making improvements like that clinic, or making improvements like replacing the low HMO with the NHP, are good for us, but it still comes down to, what are the employees going to pay? And that's why we pulled out of the coalition last year, and we're going to stay out of the coalition, because in the exchanges that I saw that took place about this, what was deemed at that time coalition bargaining, I think they've made pretty clear that no, we have collective bargaining agreements. They're going to stand by them, and which leaves us out on our own, which is where we put ourselves last year. I'm not saying that they put us in this position. We chose this position last year, and we stand by that choice. So for us, we have negotiations coming up next month for a new collective bargaining agreement, and we think that healthcare should be part of those negotiations, the broad negotiations for an entire successor bargaining agreement, and no longer separate negotiations that are not part of that pie. Because you can't, when we talk about what we're going to take out of employees' paychecks in order to afford healthcare, and we can debate, should we operate that way? Should it be employer-based healthcare? Those are separate and apart from collective bargaining. But the fact of the matter is that under our current system, healthcare system in the United States, it's employer-based. We rely upon you to provide us access to healthcare, and the cost that we have to pay for that should be part of the negotiations for the wages that we earn for the services that we provide and the jobs that we perform. So, to us, this shouldn't be a separate discussion from those negotiations.
Understood. We'll have to look into that on our side, and just exactly, we'll reconnect with you about that then.
Yeah, I understand. I mean, and I'm not saying that our position is that the district should provide different benefits to each of its bargaining units. We understand that there are efficiencies and economies of scale, right? We understand that, but the cost that the district chooses to pass along to its employees, those don't have to be the same. And as the same as the position that we took last year, we think the district should adopt a position that, we are going to pass along these costs based on income and based on ability to pay. The district, we think, should be looking to each of its employees and saying, we need to provide you access to healthcare. And when we see rate increases like those that are contained in the PBA and CTA contracts, while they may be comfortable with those increases, we are not, because we can't afford them. $36 a month to some employees may not sound like much of an increase, but to others, that's significant. And it makes a difference in they're having to choose between, do I buy food? How do I pay for my childcare? How do I pay for fuel and cars? So to us, we think the district needs to adopt an approach of, we're going to scale this based on ability to pay, based on the wages that you earn. And, that's the position that we took last year. Obviously, it wasn't successful, but we still maintain that position. On a separate note, Tim, I have a question. So when we were resolving the impasse, the school district took a position that it had Me Too clauses with the PBA and CTA that said if we charge the SEIU employees less, then we would have to match those rates for PBA and CTA. I've looked through the collective bargaining agreements. I've watched the negotiation sessions. I've put in public records requests. I cannot find that Me Too clause. Can you tell me where that comes from?
I believe it was done through, it was an email with parts of the coalition who, when signing the agreement, said that, you know, if other group is able to secure a better rate, that they would be entitled to it. So it was in writing. I believe it was with CTA really asking that question or asking for us to agree to that, which we did.
Yeah, I did see those emails with Justin Katzman, but so effectively that's a handshake deal, not a collective bargaining agreement, not a ratified agreement.
Sure.
It's not even, a contract in writing. I mean, that's just, hey, if we see that SEIU pulled out of this coalition, if they end up doing something better, we're going to get that too, right? Oh, yeah, sure. So it's not an enforceable agreement.
We would consider it would be, yeah, we wouldn't, if we were to say, yeah, we agreed to that, even in an email or a discussion, a handshake, whatever you want to call it, that means something to us. We wouldn't turn around and do something different, say, oh yeah, we're just kidding, that we wouldn't do that. So to us, it's enforceable. That's how we would approach that. Absolutely.
All right.
And you could expect the same. That's how we're going to deal with our unions. We're not, that would be the end of any kind of relationship. I think you'd have.
Yeah. I appreciate that. I appreciate that. And, if I, have a handshake deal with somebody, I expect that will be the deal, absolutely. But I just wanted, it's been bothering me for 6 months now.
Sure.
At that hearing, it was said that no, our contracts require it, and I'm going, this is not in the contracts. I do not see this, and so
right.
I'm just curious. Yep. All right.
Heather, you had something?
Yes, I just wanted to make sure to put something on the record that our plan was not in the need for the increased premiums because we were not being innovative and trying to make changes within the plan. So over the past 10 years, the reason why we didn't have to have premium increases is because we were constantly making changes to the plan. And also the premiums were covering what those plan costs were. It truly wasn't until COVID that we did see that increase due to medical inflation that we then had to make further adjustments. And so we did wait. I don't want to rehash everything because we heard it all last year, but I don't want it to seem like we're holding off on making changes previously. We really weren't. It was looking to see how it settled after COVID. After we knew with that increase in premiums that we agreed to last year, we were going to continue to make changes and cost containment. That's what you have to do with a self-insurance plan in order to properly manage it. So I just wanted to make sure that was on the record. That's all.
Yeah, I wasn't, Heather, when I was talking about innovative and consumer driven, I was specifically talking about the Surest plan and that fourth option. That wasn't in regard to anything else.
Mr. Pegg?
Yeah, a comment and a question. First of all, the comment is that the option to have clinics is a great idea because we have more and more physicians and plans are going to concierge care, and it makes it difficult for our members to be able to get quality care. So I appreciate that effort. But the question I have is, I always do, this really is the same thing I've discussed before. We're now giving a lot of different options and a lot of thought that the employees have to think about as they make decisions in regard to their health care. What's our educational? What are we going to do to teach them about this and how we're going to communicate it? Because there's a lot here to really, it used to be, if you have hair the color of mine, you either checked, yes, I want health care, or no, I'll get my own. Mm-hmm. Now we're looking at quite a few different choices. And I think it's going to be important for us to have a plan put together to communicate the changes and the options that are going to be available, especially when we talk about the health savings account. I agree with that 100%. This is something I don't think enough employees take an opportunity to use because it is beneficial to them both for their healthcare and for their tax purposes. So I wish that we could do a better job of informing of that. So what's our plan?
I can speak to that a little bit. We are working with People One representatives and our communications team on a robust communication plan. And also the Surest plan, we will work on a robust, education plan. A lot of this will coincide with and around open enrollment because that's the time of year when everybody's thinking about their health plan, but also will extend beyond that. And, our communication materials, our customer service outreach, all of those components will encompass communications that help employees to better understand their benefits.
And Nancy, with that, speaking for the staff association only, whatever you can get to me or Eric as early as possible, we'll do our best to emphasize the communication within our group if we can get that information as early as possible so we can help get that out to them. Because I just want people to be able to make the right decision for them personally, and rather than just checking yes or no. And I think it's important that we get that information and education out to them.
Absolutely. We appreciate that assistance.
All right. Any other questions? All right. Ms. Foy, we're going to talk about it, some things on our side, but I'll probably reach out to you in the very near future to discuss just where we're going, how we're going forward with everything. All right.
Yeah, that'd be great. Look forward to it.
Sounds good. All right. Thanks, everybody. Appreciate your time today.
Thanks for the information. We appreciate it.